A very warm welcome, everyone, to the first seminar in our series at this term. I'm delighted to welcome Holly. Holly has been working with us for a few months on a really interesting project looking at web-based mental health applications as a postdoc, but she's here today to talk to us about some of the work she was doing before she came here as part of her doctorate. So she did this work when she was doing a doctorate in London. It was about kind of the role of illness belief models in how young people experience and respond to anxiety and depression. Holly has skills both in quantitative and qualitative work, bringing those mixed methods in. So I'm really excited to learn from you, Holly, about what happens. We have 45 minutes together. For those of you that want to ask questions, Holly will be taking questions at the end. Please do put your questions in the chat as she goes, in the questions and answers as she goes along, and I'll call on you and ask you to say the questions directly when the time comes, if you'd like to. So thank you very much, Holly.
Thanks, Mina. Thanks for the introduction. So yes, I'm really pleased to be able to present today on work that I carried out during my doctoral research, which looked at young people's illness belief models or illness representations, their treatment expectations and treatment outcomes. Before I start, I'd just like to kind of preface what I'm about to say in my presentation by saying that the research on illness representations as applied to mental health originates from and has been adapted from the physical health literature, so therefore uses fairly kind of medical language and terminology. So by using the term illness representations, I'm not necessarily saying that anxiety and depression are illnesses, but rather just using the terminology that already exists for the purposes of consistency and continuity. So just to give you a bit of an overview of what I'll cover during my presentation, I'll start off by saying a bit about what illness representations are and what we know so far about young people's representations of their mental health problems. I'll then share the findings of a few studies I carried out during my PhD, which hopefully extended our understanding of what was previously known and gave us some greater insight. And then I'll end by commenting on the kind of key clinical implications and some important future directions for research. And this is a relatively new area of research. It's relatively underexplored. So there's a lot we don't yet know. So I particularly welcome any feedback at the end about the kind of proposed next steps and the clinical utility of this work, really. So what led us to look at illness receptions? Well, we know that anxiety and depression are highly prevalent in young people, and there's evidence to suggest that the number of young people experiencing these difficulties is increasing. Despite this kind of clear demand and the many young people who would potentially benefit from support, we also know that from a meta-analysis I conducted with colleagues that only about 40% of young people who access services, so access CAMS, for their anxiety and depression show measurable improvement in symptoms. A small proportion, of course, will deteriorate as would be expected, and many show no reliable change. So from our meta-analysis, it was around 40 to 50% that actually stayed the same. And I guess the caveat here is that this type of research is reliant upon routinely collected observational data, which of course has limitations. And when conducting our meta-analysis here, one of the key limitations related to data quality issues. And that included the variety of outcome domains looked at. So for example, symptoms, quality of life, functioning, outcome measures used. So lots of different measures used for symptoms of anxiety and symptoms of depression. And then different metrics of change. So some studies reported reliable change, whereas others reported clinical change or reliable recovery even. And then finally, the different time points used. So the studies just used a variety of different time points too. So I think although treatments delivered in routine settings will of course be helpful for a lot of young people, there are certainly significant challenges with engagement. So many treatments end prematurely, for example, and a consistent finding seems to be that a high proportion of young people don't meet the criteria for measurable improvement despite having had access to some form of intervention. The other interesting thing is that in meta-analyses, including our own, it seems to be that treatment outcomes have remained relatively stable over time, and a consistent finding is that study year doesn't seem to be associated with effect size. So we found that in our review, and then Weiss and colleagues found that in their large meta-analysis in 2017 as well. So I think taking together these figures raise some important questions about, firstly, how can we best support the young people who have accessed treatment but who haven't been helped? And then secondly, what can we do to enhance the effectiveness of the existing treatments that we have available to us? So one possible approach to this is to better understand how young people perceive and cognitively represent the course, severity, impact, and treatability of their anxiety and depression. As these representations, these kind of mental maps that we hold in our head, guide behaviours and attitudes. So attitudes, for example, towards mental health services, help seeking, engagement is a really important one, self-management, treatment expectations is another really important one, I think. All of these things have the impact to have the potential to impact treatment outcomes, and all of these things are guided to some degree by representations. So as I just said, these representations are important as they guide attitudes and behaviours. And the dominant conceptual model to investigate cognitive representations of illness and the processes by which individuals respond to health threats and illness is called the common sense model of self-regulation, or the CSM. And it was originally developed in the 80s by someone called Howard Leventhal, and has been extended and developed since then. So the model was originally developed in physical health contexts to understand how people respond to and cope with chronic physical illnesses, so like cancer, diabetes, arthritis. And then the model, as I said, has been extended and kind of developed since then, but it's been highly influential in health psychology and has really advanced understanding of how people manage and cope with their health conditions. Now, what this model tells us is that in the face of health threats, so for example, a new set of symptoms or a new diagnosis, individuals respond both cognitively and emotionally. And the model delineates the parallel cognitive processing of how people regulate the response. So for example, why has this happened to me? Is it treatable? To the individual's emotional response. So how do I feel about this? What can I do to make myself feel better about it? So the emotional response, which is on the bottom line here, may involve feelings of worry, anger, fear. And then in parallel, individuals actively build a cognitive representation, which is on the top line. And I've highlighted the kind of key domains in orange. And I'll say a bit more about this bit in orange in my next slide. So it includes things like cause, duration, curability, control. So someone will build representations in their mind about what caused their diabetes, for example, how long it will last, do they think it's curable or treatable? And then if we move along the model from representations, individuals then develop coping behaviours to try and deal with both the cognitive and emotional response. So those coping behaviours could be adaptive or maladaptive, but things like seeking support from friends, help seeking from a professional, treatment adherence. And then finally, if we move along the model, one more column, it moves to the kind of appraisal processes. So appraising the effectiveness of these coping strategies and their outcomes. So how well is that strategy working to reduce symptom severity, for example? And then these appraisals in turn feed back into the formation and reformation of illness representations and coping strategies. And based on these appraisals, individuals update their coping response and may opt to adapt or modify the coping response, or maybe scrap it altogether or come up with something new. So this model is very dynamic. This process is dynamic. And the purpose is that individuals arrive at a coping procedure that produces the greatest success in managing the health threat and producing the best outcome for them. So I'm just briefly going to say a few words about the different domains that were highlighted in orange in this slide. So Leventhal suggests that these beliefs are complex, idiosyncratic, and he classified 5 representations which form the wider beliefs. So they're in purple on this slide. So identity is the label an individual attributes to their condition, along with the symptoms that go with it. Then cause is an individual's perception of what they think caused the condition, and that may or may not be medically accurate. So This tends to be based on personal experience as well as the opinions and discourses of significant others around them, and it's particularly culturally sensitive. And we know that causal beliefs are often particularly salient after the initial diagnosis of an illness, as someone kind of seeks to understand why this has happened to them, you know, what's caused this to happen. Timeline is the predictive belief about duration. So is this an acute illness, relapse remitting, is it progressive? Consequences is the belief a person holds about the impact it will have on their life. And that may change in something more realistic over time. And then finally, the curability controllability domain is the belief about whether the illness can be cured or kept under control, and the degree to which an individual plays a part in achieving this. So personal coping, for example, medications, surgery, lifestyle changes. And then finally, 2 further subskills were added later on, so emotional representations and coherence. So illness coherence is more about the extent to which a patient's illness representations provide a coherent understanding of the illness. And I think the important thing about representations is that they're based on an individual's knowledge and experience, and the knowledge and experience of those close to them and the current, I guess, cultural context or historical social context. And interestingly, 2 people who are diagnosed with the same illness on the same day by the same doctor in the same hospital may have very different illness belief models, because we all have different experiences, memories, knowledge, upbringing. So 2 people diagnosed with the same type of cancer on the same day may have very different views about what caused their cancer, how treatable it is, even what symptoms or bodily sensations they attribute to that diagnosis. So, yeah, why is this important then? So, as I've already mentioned, illness representations are associated with attitudes and behaviours which have a knock-on effect on outcomes. And this is true across a range of illnesses and populations. So, for example, having greater perceived controllability over your condition is associated with more adaptive coping strategies, while perceiving an illness as being highly symptomatic with a chronic timeline and serious consequences is associated with more maladaptive coping strategies. And these relationships, I think, really highlight the importance of subjective representations for understanding how people cope with their illnesses. And these associations are found in adult samples, but also in adolescent and youth samples and child samples too. So from the physical health literature, we know illness representations are important, but what about for mental health? Well, we know far less about this. Some work's been done looking at illness perceptions in adults with schizophrenia and depression, but very few studies have sought to determine the relationship between illness beliefs and outcomes for young people with anxiety and depression, or generally in terms of the mental health. And the studies that do exist tend to use very diverse methodologies, and there isn't really a consistent theoretical framework of illness belief models, which has resulted in quite a disparate literature and a kind of lack of shared language between the studies and a common theoretical frame. So, given the lack of theoretical frame, there is a need for a more kind of coherent and complete picture of young people's illness beliefs. So we conducted a study to address this by undertaking the very first, to our knowledge, application of the original CSM model to young people with anxiety and depression. So for this study, we used qualitative methods to identify and characterise anxiety and depression-specific illness perception. And we did this to try and elicit the beliefs in young people's own words. So we interviewed 26 young people who were around, the average age was around 20 when we interviewed them. And we analysed the data using primarily deductive thematic analysis. So what were our key findings? Well, across the 26 interviews, we identified 5 themes, which are presented here in the left-hand column of this table. Anxiety and depression were perceived as being highly symptomatic, long-lasting conditions that would be present throughout the life, but perhaps coming and going in waves, kind of more relapse-remitting nature, so sometimes be worse than others. but having a really pervasive and wide-ranging impact on life, both now and in the future as well. But while the young people described pervasive negative impacts of anxiety and depression, they also frequently told me about more positive impacts or kind of benefits. So things like personal growth, being more open-minded, I'm trying to think what else, being more empathetic towards others, feeling things more deeply. So that was really interesting because that wasn't a question I set out to ask, but it was something that many young people spoke about. And finally, there was a lot of diversity in young people's kind of prognostic expectations about their outcomes and treatment effectiveness. So I guess the other thing to say is that these themes were broadly consistent with the original domains outlined in Leventhal's model, which suggests that illness representations share a common conceptual structure between physical and mental health conditions, and that there may be structural parallels in how young people cognitively represent anxiety and depression, so things like cause, consequences, controllability, as in physical health conditions. And although this study supported a kind of common structure, as I just mentioned, the content of these beliefs was very complex and specific to anxiety and depression. And I'm not going to go into too much detail about all 5 themes, but I thought I'd just pick out this one theme that I thought was particularly interesting. So recovery and learning to cope were viewed as a very non-linear complex journey, which often took time to achieve. And several young people spoke of a kind of gradual change in their mindset, which shifted from a predominantly kind of recovery orientated view in which the treatment and cures to anxiety and depression were seen as external to them, and recovery from symptoms appeared more achievable, to a view which focused more on kind of longer tail self-management and an internal locus of control. And several young people described that their agency and ability to manage the symptoms had actually improved with time. And I think one thing I thought was quite interesting about this theme is that this kind of complex, non-linear nature of recovery and the process to recovery and kind of building of resilience strategies over time is largely absent from most research in the kind of physical health literature relating to this, relating to illness perceptions. So it seems to be something that may be specific or unique to this group. So that's quite an interesting finding, I think. In our study, young people placed a strong emphasis on learning to cope with anxiety and depression, and this finding was in line with existing qualitative research about young people's treatment outcome priorities, suggesting that young people assign similar levels of importance to learning to cope and self-management as they do to symptom reduction. And we have an article, a preprint available at the moment that was led by my colleague Carolyn Krauss, in which coping was reported by young people as being a key priority. So I think it's quite important. But learning to cope, it seems, in kind of trials and meta-analysis isn't necessarily the focus. So for example, in a systematic review, also led by Carolyn, we found that treatment trials tend to conceive symptoms as acute rather than longer term problems, and focusing on achieving symptom remission as a marker of treatment success. So our findings kind of suggest that there may be a discrepancy between this focus that we often see in RCTs and in intervention effectiveness studies with the focus on acute symptom management, and then young people's kind of longer term view of their anxiety and depression. So this long-term view of anxiety was also associated with this kind of desire to manage symptoms across time. So in terms of implications, it may be that to prevent young people disengaging from treatments that they find unhelpful and to better meet the needs of those with longer-term anxiety and depression, it may be that services try to incorporate young people's outcome priorities and cognitive representations into shared decision-making about treatment, and the increasing the congruence between young people, clinicians, and family members may serve to improve treatment engagement. So the final thing I will mention is that in order to advance our understanding and investigate the extent to which these illness perceptions are associated with important treatment-related outcomes, and to kind of move towards more intervention-related research and development, a suitable, validated tool was needed to measure illness perceptions in young people in a kind of more consistent way than using qualitative methods. So that brings me on nicely to the second study that I wanted to mention. So the qualitative study that I've just discussed informed a parallel effort to adapt and validate a quantitative measurement instrument called the Revised Illness Perceptions Questionnaire, or the IPQR, which is a really well-established measure with sound psychometric properties across health conditions and contexts. And this measure measures perceptions across the 7 representation domains that I mentioned earlier in those kind of purple bubbles before. And a shorter 9-item version has also been developed called the BIPQ. But although this measure is very well established, a key limitation of these measures in general is that they're generic measures of illness representations, and they lack kind of specificity to individual health conditions. And the majority of research conducted to date on illness representations has tended to use these generic measures where adaptations have been limited to just kind of swapping out the word illness to the illness of interest. So you can see on this slide here, put a kind of example of some of the questions in the original. So, for example, my illness will last a short time, maybe substituted to my arthritis will last a short time. So measures tend to be, adaptations tend to be limited to that substitution. But there's been some criticism that using this generic measure for different illness groups, as I say, doesn't provide a high enough degree of specificity or insight about the kind of unique and complex nature of illness beliefs held by different populations and groups. So to address this, we aim to develop an anxiety and depression specific measure of illness perceptions, along with the brief version. So 4 in total, 1 for anxiety, 1 for depression, and the brief versions for both. And to do this, we conducted a mixed methods study. So it consisted of 2 rounds of qualitative interviews and then a cross-sectional quantitative study as well. So I followed a series of steps to modify and validate the tools. So you can see them here. There are 5 different phases. So as I say, there was a qualitative phase to elicit the anxiety and depression specific illness perceptions, and then using this data, we made modifications to the original measure based on the language used by the young people and their illness representations. And then a key theme from the interview that I kind of touched on earlier was that in addition to the negative consequences, young people had experienced positive consequences as a result of their mental health problems. So in order to capture this in the new tool, we actually added a new 5-item positive consequences subscale for our new anxiety and depression specific tool. So after the initial modifications and item development, we then conducted another 13 think aloud interviews to assess, I guess, the face validity of the new measure and to determine if it was understood in the expected way. So were the items being read and understood as they were intended to? And actually this stage was, I think, one of the most invaluable studies that I did during this whole kind of program of work, because young people just provided so many helpful suggestions and insights about how to make the measure better. And I think that really improved the clarity and usability of the measures. So for example, within the Coherence subscale, there was a consistent view from young people that the term puzzling may pose a problem for some young people. So there was an item that said, the symptoms of my anxiety are puzzling to me. And it was suggested that while this term may make sense for native English speakers, it may be difficult to decipher if English isn't your first language or for people who maybe don't interpret language literally. So we swapped that word out, we swapped puzzling out for, I'm trying to remember, confusing. So that's just one example, but we made several revisions. And then finally, we recruited a cross-sectional sample of 350 young people to complete the various measures. And I did a randomized split of the data, did an exploratory facts analysis on one half followed by a confirmatory factor analysis on the other half, to see how well the newly modified items represented the expected construct of the original model, tested the internal consistency, and retest reliability at 2-week follow-up. And then the final thing that I did was check the construct validity by checking if the dimensions of each scale correlated in the expected way, so consistent with the original model and previous research, and check the associations between the different subscales with outcomes such as distress, coping, well-being, treatment outcome expectations. And then in order to validate the brief measure, we cross-validated with the long version on each of the equivalent dimensions. So without getting too bogged down with too much detail about the statistical analysis, a kind of high-level summary of the results are that the measure is largely conformed to the original factor structure of Leventhal's model. Both measures showed acceptable model fit with high factor loadings and excellent internal consistency, test-retest reliability across subscales, and concurrent validity as well. The results also confirmed that the equivalent scales on the brief measure and the long version were appropriately correlated, indicating concurrent validity with both sets of measures. So that was important. And yeah, I guess this study suggests that young people's beliefs about anxiety and depression are multifactorial and complex, but can be organized according to the underlying dimensions of Leventhal's model. So I think this is a really important step because it means we can now reliably measure illness representations in this group. So I think, yeah, the key implication here is that I think now we've got 4 tools that were developed as part of this study that provide researchers and clinicians with a means to track changes in both cognitive and emotional representations, which hopefully in the future can be targets for psychological interventions designed to improve outcomes. And I think the brief versions that we developed have the kind of added benefit of providing a simple and rapid assessment of illness perception. So I think those will be particularly useful for purposes of research going forward. Okay, so I think for me, there are some really exciting possibilities for this area of research. We've made some really important steps in improving understanding so far of how young people perceive anxiety and depression, but I think there's still a great deal that we don't know yet, and there's still many unanswered questions. So we're kind of at the stage now where I'm thinking about whether there's scope to build on what we've already done and trying to address some of the gaps in our understanding. We're particularly interested to know, I think from clinicians' perspectives, about the potential usefulness of this, and yeah, would this be useful in a clinical context to their work to kind of gauge the clinical impact? In terms of next steps for research, we're thinking, you know, using quantitative methods, investigating the extent to which illness perceptions are associated with important treatment-related outcomes, so help seeking, treatment engagement, symptom change and expectations. And the idea would be to do this both before, during and after treatment. So using a research design that captures that kind of dynamic processes present in the model. So perhaps some kind of cross-lagged panel design or intervention design to model that temporal change. And then of course, depending on the results, illness perceptions may be a useful target for interventions. So CBT, for example, could be harnessed to create more adaptive illness belief models with the aim of improving self-management. But yeah, these are all at an idea stage at the moment. So yeah, any thoughts on yeah, the usefulness of this in future directions would be more than welcome. But this is where we're up to at the moment. So I'll just end by saying thank you for listening. And I'd just like to acknowledge the young people and clinicians who shared their experiences and their time with us. And of course, a big thank you to my wonderful collaborators and co-authors too. So thank you.
Great. Thank you so much, Holly. So important, so much to think about, because it's, I suppose, talking not only about anxiety and depression and mental illness, but all illness as a whole and how it's perceived and how young people perceive it. So thank you so much. So interesting. As ever, you brought your usual thoughtful approach to this issue, and it's really interesting.